So I have been asked to just give a few more words of overview before we sort of dive into a conversation here and sort of highlight a couple additional points. So for me, the one number that's really important is $3.5 trillion. So $3.5 trillion is approximately what we spend every year on medical care in the United States. And we've heard some big numbers. Warren Buffett yesterday was throwing around some even bigger numbers. But they're hard to wrap your head around. And one way I think about it is that, well, does anybody think about this in your head? What's 1% of $3.5 trillion? Kind of get it in your head. 1% is $35 billion. Now, that still is a big number and hard to wrap your head around. So the way I think about it, Head Start in the United States costs about $8 billion a year. That's 1/4 of 1% of what we spend on medical care, and we turn away half the children who are eligible because we don't have enough money. So the way a colleague of mine says is the status quo is stupid and expensive. We're spending money in the wrong places. We're spending it on prison, we're spending it on special education, we're spending it on chronic disease, and we're not spending it on preschool and on parks and on summer camp. And even worse, in the slide you see here, most of that money, 93% at least, I've heard as high as 95 to 97%, goes into medical care. Very little of it goes into public health or health promotion. And what you see there is, and this has come up before, medical care is not the primary cause of early mortality or of disease. It's really the other factors there, the things that happen in your neighborhood, the choices you have that you can make. This probably looks familiar, at least the idea that your zip code is more important than your genetic code. And this is just a map of Cleveland. These are two neighborhoods that are 3 miles apart. You can see the life expectancy there is 64 in one neighborhood and 88. There's a 24-year life expectancy gap there. Now to put that in context, two things. One is, this is true in almost every city in the United States. This is not a Cleveland-specific issue. A second point is, that gap is equivalent to the gap between Afghanistan or Zimbabwe and Switzerland. And that's happening in every American city. And that happens because of the choices you have available to you early in life. A lot of those things are tied to income levels in those neighborhoods, the opportunities you have, and issues around racial discrimination and other forms of oppression. So what we're going to talk about here today is really what's the role of healthcare? Can healthcare solve this problem, and should healthcare solve this problem? What you see there are some of the social determinants, the circles there, the food, the parks, the education, the housing. And these I'm just going to leave up. We won't get into them, at least right now. We may get into them a bit, is some examples. There are examples of healthcare systems beginning to dive into this. Stanford Hospital is building, in Connecticut is building housing. The Cooper University healthcare system is working on education. Philadelphia Children's Hospital focused on both clinical care, access to clinical care, and recreation simultaneously. But notice how many of those circles are not checked off. In my mind, purpose-built communities is one of the few sort of efforts that's really doing holistic community development, which is why Bechara was so impressed when he came to see Eastlake and Grove Park. So with that, I wanted to, I have been asked to sort of lead this, although Bechara told me he's going to ask me as many questions too, so now I'm nervous. So the first thing is, so you're a Chief Community Health Officer, so CCHO, and as far as I know, probably the first or only in the country. And so I think talking a little bit about what that is at Kaiser Permanente and how is Kaiser Permanente set up differently, or can you give us a little foundation on what's the structure of Kaiser Permanente and why and how are you more interested perhaps in community health than many other healthcare systems?
Yeah, thank you. Thank you, Doug, for the introduction. David, thank you. And thank you so much, everybody, for inviting me to join and spend part of the morning with you. So Kaiser Permanente is one of the largest integrated healthcare delivery system in the country. We do both. We're a health plan and a healthcare delivery system. And we have around 12 million members across our footprints in the states where we operate. And if you look at our mission, we're a 70-plus year organization, and we've had the same exact mission for 70-plus years, and we're about improving the health and well-being of our members and improving the health and well-being of our communities. And for us, those really go hand in hand. Because if you think about it, there is no way we can improve the health and well-being of communities if we don't do a really good job at improving the health and well-being of our 12 million members. But at the same time, we realize very well that there is no way we can optimize the health and well-being of our 12 million members if we don't do a really good job at improving the conditions where those members live. And when we do that, when we work on improving the conditions where our members live, not only our 12 million members would benefit, but really all 65 million people who live in our communities would benefit from those improvements. So for us as an organization working in community health, is not just the nice thing to do, or this is the right thing to do, or these are all the things we do to maintain our tax-exempt status. Mm-hmm. Doing community health work is really core to what we do as an organization. And that's why when you look at our organizational structure, we have a chief medical officer for our 12 million members to make sure that we're doing the best we can when it comes to quality of care and care outcomes for those members. And my role is really to make sure that we're doing the best we can to improve the conditions where the 65 million people who live in our communities are benefiting from. Mm-hmm. So I hope that makes sense.
Let that sink in. What I want to put a point specifically is that Kaiser Permanente is one of the rare examples, frankly, where they're both the insurer and the healthcare provider. What that means is, unlike, and I'm going to be really frank here, unlike most healthcare systems in the country, they don't want you to come into the hospital because it costs them money. Frankly, a lot of healthcare systems need to keep the beds full. And this is just the way the system's set up. It's not their fault. They want to make people healthier, but they also need to keep the beds full. And Kaiser Permanente's system is a little bit different than that.
I'll codify the statements.
Please.
It's not like we don't want our members to come to our hospitals.
Oh, yeah. Fair enough.
We want our members to thrive and be healthy and enjoy their lives, and we're here to support them for that. And we absolutely want them to come in when they need to come in.
Yes.
But we want to create the best environments for them to thrive in their communities.
Exactly. But it's a very different business model, and that is an important characteristic. So where are you beginning to see, or where are you seeing Kaiser Permanente's role in this larger sort of community investment, that what you saw in Eastlake, what you saw in Grove Park? What's the role for Kaiser Permanente in that work?
Yeah, so I mean, for us, so I've been now with Kaiser Permanente for a little less than a year, and we've been, I've been spending a lot of time talking to a lot of folks within the organization, some of our national partners, some of our local community partners. I got a chance to come in and visit with the Eastlake community, with the Grove Park community in Atlanta. I know Molly Haynes is right here from Portland, where she's engaged with the Rosewood communities. So as we were exploring different models out there and really looking at what Kaiser Permanente has done and has been engaged in for the last 10 to 15 years in the community health space, I think we're at a point where we're saying, for us to be really transformative and improve community health, we have to focus on individual health. That's really, really important, and that includes not just the clinical services, but also the wraparound services that people would need, and especially people who are most vulnerable. But we also have to focus on the conditions of health where people are living in, and whether the work like the Eastlake work or the work that's happening now in Grove Park, or our own work that we've been leading in West Baltimore and Oakland and West LA, as well as our work in the school districts where we're in 400 plus schools, or our work with cities where we've done work with over 325 cities over the last 10 years to really focus on changing the built environment, the policies, the systems around healthy eating and active living. All this work is really core to the way we improve community health. And again, I had the opportunity over the last year to really dig deep and see what's happening in Oakland, for example. We have a council in Oakland called Oakland Thrives that is co-chaired by our region president for Northern California and the mayor of Oakland that include a wide range of community-based organizations, faith-based organizations, government agencies that really are working together to try to see what is it that we can do along 5 main pillars. What do we do to improve the health of the community? What do we do to improve housing in the community? What do we do to improve economic vitality of a community? What do we do to address violence in a community? And what do we do to address education in that community? So the work, as I'm seeing it evolve in Oakland through the Oakland Thrives efforts, bring these 5 very important impact tables and people around those impact tables to identify strategies and whether they're policies or programmatic interventions to address all these 5 pillars, as you see from the slide that we have here, are really critical to empowering and supporting people to thrive in their communities. And we have countless examples of this work.
And do you feel like, so this is a new title, the Chief Community Health Officer. Do you see things changing going forward, or are you beginning to envision, now that you've been there a little while, Kaiser's always been more active, or been very active in the community and thinking about referrals and strengthening the systems and thinking about general health. How are things going to change going forward, do you think? How will you tighten that up or become even more aggressive, perhaps?
Yeah, I mean, I think, and we're still in a strategy, refresh, if you want. But I think we're at a point right now where we truly believe that there are 3 areas of focus if we want to truly improve community health. We absolutely have to focus on individual health with the clinical and the wraparound services. And I want to give just a couple of examples because I think that would give folks the, kind of really what it means that we're not only providing medications to our members, but we're also thinking about the social wraparound services that are important. One of the areas that I've been spending a lot of time on recently is around food insecurity. And what we've learned from surveying our own members, screening our own members, these are folks who have Kaiser Permanente card. In Colorado, for example, almost 6% of our seniors who have Kaiser Permanente card have food insecurity issues. And 2 of the pediatrics clinics in Colorado as well, one has 12%, the other has 16%. Of the kids come from families with food insecurity. We looked at our Medicaid members in California. Almost 240,000 of those members qualify for food stamps, but they don't get it. And just if you think about that number, 238,000 times the dollar amount that folks would get to be able to afford fruit and vegetables and food to put at their tables at the end of the day, that's almost $400 million of cash that would come to the pockets of those who are most vulnerable in our own members to be able to purchase food. Simple things that we really need to be able to focus on to take to the next level. So that's one area of focus. What is it that we're doing to really optimize the clinical care for individuals as a key part of improving community health? The second area of focus is what do we do to improve the conditions where people live? And, the work that I've mentioned in Oakland is one example. We're doing some really good work also in Baltimore, where we narrowed the focus on one zip code in West Baltimore, the 21223 zip code. And when you mentioned the difference in life expectancy, the difference in life expectancy between the state of Maryland and this one specific zip code is 11 and a half years. Wow. And we know unemployment rate is 4.5 times higher. The graduation rate is a lot lower. Recidivism to that community is a lot higher than the rest of Baltimore. So we focused efforts along similar, economic issues, housing issues, violence issues, and education issues in that zip code. But also I think I've been really impressed with the work that Kaiser Permanente has done and other healthcare systems are stepping up to do right now when it comes to the role of these organizations as anchor institutions in their communities. I look at, we procure lots and lots of stuff. And we purchase billions of dollars worth of stuff. So I'm really excited to learn that in 2016, $1.6 billion with a B out of our procurement for Kaiser Permanente went to minority and women-owned businesses. And that, to me, is really important because that tells us that as a purchasing organization that's spending money in our communities, the way we spend those dollars would have a big impact on the health and well-being of communities. I mean, the way we think about building facilities. I had the opportunity to tour a new medical office building in Baldwin Hills neighborhood in LA. It's a neighborhood that's been struggling for a while, but it's a great, vibrant community where we built a brand new medical office building there. And we've made a commitment as we were redeveloping the 8.2 acres of land there that we wanted to engage the community from the get-go. What do we want in that space? What percentage of that space we'd like it, the community would like it to be green space? We have a 2-mile walking path there that's open to the community. As part of the build out, we make sure there's a community space that's open to our community partners there. We've made a commitment to hire locally for the construction even, where 48% of construction workers were hired from within 5 miles of that medical office building. And we've also made a commitment that we'd want to make sure that we're giving opportunities for folks who needed a second chance. So we had people who participated in that project with over 200 years of prison time who helped build that facility. The art that we put in that facility is all commissioned by local artists. So I mean, I think as we think about the role of health systems could play in procurement and investments and building and hiring, there's a big role that we can play. And then the last part where I think is really an important area of focus for us on community health is around innovation. And I think I want to just spend a moment here because I think when we think about all these emerging promising technologies, and not just technologies, but also social innovation. But let me just spend a minute on the emerging technologies. We think about artificial intelligence, blockchain, virtual reality, augmented reality, 3D printing. We think about all these emerging promising technologies from a healthcare delivery system. How do we leverage all of those on the clinical space? And we're starting to ask ourselves at Kaiser Permanente, what would it look like if we extend that continuum to think about these emerging promising technologies, not just from a clinical perspective, but also from a community health perspective. And I think that's an area that we will be learning a lot as we develop it, and we will be learning from each other and from others outside of Kaiser Permanente, but I'm really excited about it.
Yeah, one concept that Bechara was bringing up that I think is important, have folks heard of the idea of an anchor institution? Is that familiar? The buy local, hire local, invest local, and that's really what we're getting towards. And you know, another piece to that, how does, and this is another familiar concept I think to a lot of folks here, is community benefit. So I find when I speak to healthcare systems that they often immediately divert to just community benefit as the role of the hospital. So how does that fit in with the sort of anchor role, and do they build on one another?
Yeah, so I think community benefit plays an important critical role in the way health systems contribute to community health. But it's the smaller role.
Right.
And I think it's really important that we leverage what we've learned from our community benefit work to really think broadly about the work that we could do to improve community health. You know, when you think about our community benefit budget, we're a $70 billion organization or so, and we invest almost $2.7 billion every year in community benefit. But to me, the question is, yes, those $2.7 billion are really important, and we want to optimize those, and we want to rethink how we're investing those dollars. But really, where's our procurement dollars going, and how do we leverage that? Where's our capital dollars are going, and how do we leverage those? Where's our investment dollars, and how do we leverage those? So to me, and for us as an organization, our community health work is all what we do, is how do we think about everything that we do to really help us deliver on our mission. I mean, this is core to what we do as an organization, and the community benefit is an important aspect of this work, but it's not the totality of the work that we look at to really make a difference in community health.
Yeah, and so you were Trinity Health prior, so one of the big Catholic health organizations, and most communities here don't have a Kaiser Permanente where they are. So
Not yet.
wow, see,
Just kidding. Good morning, everybody.
yeah, David Edwards wants a purpose-built community everywhere, and Bechara wants a Kaiser Permanente everywhere. So how do the communities here, given your past history, both in public health and in a non-Kaiser Permanente system, how do they approach the local hospital system or healthcare system to make the case that the work they're doing is aligned in some way? Because I think for me, this is an important issue, is most hospital systems, if you look at their missions, they all look pretty similar, right? The question is whether they're really fulfilling the mission, and I think that's one of the issues David and I have discussed is purpose-built can help them fulfill the mission they actually have stated and put out there. But how do our colleagues here reach out to perhaps the Trinities where you were before?
Yeah, I mean, the key part of all this work is around engagement, is around building relationships, is around identifying who the right people are who have influence in that health system, and spend time with these folks and get to know them. And I can tell you, I mean, I had the privilege of being part of a small federally qualified health centers where I trained and I saw patients and I was a CEO of, and I was part of bigger health systems like Trinity Health that's, in 22 states with 93 hospitals. And now I'm part of Kaiser Permanente, we're in a bunch of states and 12 million members. And I can tell you, the overwhelming majority of the people I interfaced with in healthcare system are really committed to figuring out what would it take to improve the health and well-being of communities. Because at the end of the day, we are in the health business. We want to make sure that we're creating better environments for our patients, for our members. And I think the key part is identifying who the influencers are in those health systems and build relationships with, get to know them. And honestly, we have a lot of work to do to continuously trying to educate folks in the healthcare system and outside of the healthcare system where all these things interface, where housing, economic development, legal protections, education and health, how they interface, and why it's important to think about all these different social determinants of health as key elements in providing health and well-being in community, or in supporting health and well-being of communities.
It's funny because, and I'm curious if you have the same impression. So in my medical training, I don't think it was explicitly taught, but there was an implicit, don't ask about things you can't do anything about. And I think that runs through healthcare systems as well. And this idea, and just tell me if I'm getting this wrong, but this idea of having folks here reach out to the healthcare systems and basically say, we can help you deal with the things that you want to work on but don't know how to. Is there something to that?
Yeah, I mean, and I'm a family physician, and I went through medical school too. And I thought when I was in medical school that I'm going to be able to change the world by just providing top-notch clinical care to my patients. I truly believed that.
Yeah,
I truly believed that, and
until your first actual clinical job. Right?
Well,
yeah.
And I trained at a healthcare for the homeless program, and I truly believe that if you provide top-notch care for people experiencing homelessness, you're going to be able to solve homelessness. That was my very first naive impression. But then as I start seeing more and more patients, I've started to realize that really healthcare is the tiniest portion of what we can offer and help and support people with to be able to thrive in their communities. I remember this one patient, I saw patients in the healthcare for the homeless program for years actually, and this one patient of mine, she was in her mid-30s, she was a great woman, great stories, she's very charming, very engaging, but she struggled with alcohol use, she had mental illness, and she was in and out of homelessness for so long. And I remember this one conversation with her that I had one time about all the medical issues, and she looked at me in the eye and she said, you know what? I'm glad you're talking about all these issues, but what I'm worried about tonight is it's 20 degrees below outside and I don't want to sleep in the park. And I worry that I'm not going to be able to wake up tomorrow because I might freeze sitting outside, sleeping outside. So to me, kind of how do we start getting...
Your medical education did not teach you how to respond to that, did
Exactly.
it? Yeah.
And I think part of why I'm excited also about what's happening at Kaiser Permanente today is we are starting a medical school that's really going to be focused on training the next generations of physicians with a broader lens of, yes, this is what's top-notch clinical care, but here are all these other things that's important for our healthcare providers.
Where's this new medical school?
So it's going to be based out of Southern California, Pasadena. We are really excited about that. We actually just...
It's news to me.
Yeah, so we're really excited about that.
Amazing.
I think the first group of students will be enrolled, I think, in the next year or two.
Mm-hmm. So I have one more question, and then I want to open up to the audience. But so let's just talk a little bit about sort of basically finance.
Is he asking a doctor about finance?
Yes, but given that you're now CCHO, and I raise this because so I just, some of you know, so I'm on the board of trustees for Mercy Housing, and I'm also on, as my committee membership, I'm on the board of Mercy Loan Fund, which is their internal CDFI. So strangely enough, doctors actually can learn some of these numbers. I just recently joined Dignity Health, which is based mostly on the West Coast, is one of the big Catholic health systems as well, has a subcommittee which is called the Community Economic Investment Subcommittee. They have $120 million that comes out of their corpus, out of their treasury, that is they can use to provide low interest loans. This is a healthcare system doing that. Now, I've been told that not all healthcare systems have groups of nuns telling them to spend part of their money to do this type of work. But so where can Kaiser, can every healthcare system, you're at Trinity, which is another Catholic system, can every system have an investment fund? Are you beginning to see ways where, because we talked a little bit about the hiring and the buying, what about the investing piece?
Yeah, so I do truly believe there is a big opportunity for health systems to leverage their investment portfolio for social impact investing. And, I spent a couple of years at Trinity Health, which is similar to Dignity Health, is another healthcare system. And the board of directors at Dignity Health had designated, I think by the time I was there, around $80 million or so
right.
dedicated to impact investing. And those were dollars that were going to support mixed income housing projects, or to support education projects, or to support all these other things. There's a project around access to healthy and affordable food in the Trinity Health communities. So I think that model works. It takes a lot of commitment to actually understand how it works, to build the right infrastructure, to vet these projects, evaluate these projects, and we are exploring that at Kaiser Permanente. Hopefully we'll continue to explore that, so I don't have anything to add here, but I think from my experience at Trinity Health, and I know the work that Dignity Health has done, this could be a really good vehicle for health systems to be engaged in community development that would lead to community health.
Yeah, and I'll add that part of what we're working on with the Build Healthy Places Network is identifying the different ways. So there's community benefit. There are the hiring and buying, but there's this loan fund. One can also do capital enhancement, credit enhancement. One can do revolving lines of credit. Other forms of, and this is where I think we're just beginning to delve into this and talk to hospital systems about, it's not just about grants or risking your treasury. There are a range of other financial tools in there which they're largely unfamiliar with. And it can, as those of you who are trying to build buildings and create communities, some of those those approaches can be really, really valuable. So I think, unless you have questions for me, do we have questions here in the audience? And I think there are microphones, but if you can shout really loud too. Yeah, please. You want any microphones? Okay.
Oh.
Would you prefer that? Okay. Kathleen is saying you should go to the microphone, and since we follow Kathleen's advice.
I certainly do. That's why I'm at the microphone.
Oh, okay. David Edwards is at a microphone.
I get to ask a question. one of the things you guys didn't really talk about, so one of the hobbies I've developed in the communities where I've been working is to read the community health assessments that hospitals are required to
that
provide.
That is a very sad hobby, David.
It is a kind of sad statement. And they're very interesting to read. I don't know if you guys have ever done that, but I would encourage you all to go to whatever hospital serves the community in which you're working. Go read their community health assessment. I've been deeply unimpressed with those reports for lots of reasons. Really, the two things that stand out is how they define their community that they serve is usually huge. So they have these assessments that are covering multiple counties, even though the majority of their patients may be quite close to their hospital and their facility. They define their service area in a very large way, which means that their analysis of the health challenges that that community faces tend to be very washed and out. I mean, it's not a very specific set of analyses. And the other thing that is deeply unimpressive is how unactionable these things are. They kind of identify what the issues are in that community. They will come up typically with some kind of clinical programmatic response, but nothing touches on the kinds of issues you guys have been talking about, which is how do you change the conditions in these neighborhoods or these communities to improve ultimately and attack the social determinants of health. So the real question really is for both of you, what advice would you give folks? I mean, is that process, are those community health assessments a process into these healthcare institutions? I mean, is that a way that we could help to offer up, for example, a path for them to actually implement real changes in the communities they serve that could generate the kinds of outcomes that they worry about? Or is that whole process, I swear there was a system, I won't say which city it was, but they had 6 hospitals in the city, and they did a community health assessment for every one of those hospitals. It was the exact same document. They just pasted and cut and pasted the name of the hospital into every place in that report, which just tells you how much thinking they're doing around this stuff. So I'm just interested in your thoughts on that and whether that is a path in for us.
I think the community health needs assessment is an important process that was started as a result of the ACA a few years ago. For us at Kaiser Permanente, we've been doing community health needs assessment way before the ACA required that. I would encourage you to check out our community health needs assessments. I think we've done 42 last year. And with those community health needs assessment, we actually do develop an implementation strategies plan for each one of those community health needs assessment. While I do agree with you, a lot of the community health needs assessment across the country identify clinical conditions. I think there are more and more health systems that are identifying things that are related to violence, are related to economic development, are related to education. And within even our own footprint, when you look at the top needs assessments, top needs that were identified, yes, there's the obesity, yes, there's the physical inactivity, yes, there's the asthma, but also there's a lot of these non-clinical issues that surface. And we are working on implementation strategies that target those. I think the community health needs assessment are a good vehicle for you all to engage your health systems in and make sure that these issues are surfacing to the top of that list. And because people do pay attention to them.
Let me just add actually quickly. So the community health needs assessments, they do have there's the community health improvement plan, right? The CHIP. Implementation plan is, you also have to state what you're going to do about it, right? Which is partly why they stay a little vague, some of the healthcare systems, because they don't know. So approaching in that way can help them do a better job. And I'll add that one great way of exchanging sort of expertise is to join the board of hospitals and have healthcare folks from the healthcare system join your boards. Because it's a way to start to get to know one another and offer services without kind of walking in and saying, we can do this for you. Let me go right over here.
Have you considered using applied anthropologists to train your physicians?
That's a good question that I will take back to the medical school team. I think so, but I can't answer it with lots of details. But I'll follow up with you right after.
All right, thank you.
Good morning. Thank you for your comments. So I am with a managed care company in Dayton, Ohio, mainly serving Medicaid members, and we work a lot in different communities addressing the social determinants of health. My question for you is, as we look at the difference between the way managed care and Medicaid is administered to the way other benefits, such as housing benefits or food assistance, you mentioned food stamps. There's a lot of differences in the way the programs work administratively and are funded. Do you think that there are innovations and best practices from managed care that could be applied out into communities, or that we could lend to communities to find ways to have greater innovation around the management of other community resources for low-income individuals?
Yeah, I absolutely think so. I mean, I think there's a lot of, learnings that we've had in health plans to be able to optimize care of our members that we could share with community partners. But I truly believe, I think the learnings is a lot better the other way around. And I think that, for us to be able to know what would it take to support our 238,000 Medicaid KP members in California to get signed up for food stamps, that expertise is less likely to be within Kaiser Permanente, is more likely to be with community-based organizations. So I think it's a two-way street. I truly believe it's heavier on the side from the community partners to the health plan versus the other way around. But I hope that answered the question.
Thank you very much. So my name is Kate Nolt, and I am a professor of public health and health promotion with a focus on community health as well as healthcare management. And over the years, I have encountered various experiences from people. And one that has stuck with me all these years, and I've shared with my students over the years, both graduate and undergraduate, I'm from Philadelphia, and so I'm happy to see Chop up there. Mm-hmm. But so there was a community hospital that was in a very underserved community, and at some point they merged with a larger health system, decided that one of the ways they wanted to address some of their financial issues and was to create these outpatient facilities within communities that could support them. One of the fallouts to that, though, was that they were charging insurance companies amazingly high rates for services where the national average, it was exponentially more. So for example, a CAT scan the national average for a CAT scan may be $2,500 or below. This health system started charging $7,000 and then would get paid $5,000 by the insurer. So the community started to absorb some of these costs. And it was concern. So being concerned, when I started hearing all these stories, I placed a phone call to the executive offices of that hospital and said, how do you justify doing this? And the administrator for radiology called me back and she said, I can't. We're discussing at a very high level in this system, the hospital's absorbing some of the costs of these fancy outpatient facilities. And I said, and the patients who can't afford it are being charged some of this. So I'd appreciate your feedback on maybe how Kaiser Permanente does this, or your thoughts on how to avoid these. You open these wonderful outpatient facilities in the communities, but they're absorbing the costs.
Yeah.
Thank you.
Thank you for the question. I mean, to me, the way I would approach this question is just by going back to the basics of how do people get healthcare services in this country? And for years, you have those who have insurance and those who are uninsured or underinsured. And at some point, that $3.5 trillion that's paying for our healthcare costs need to be figured out how it's collected so that the health system is resourced to provide services to people. I think, to me, it really boils down to what is it that we're doing as a country to make sure that more and more people have access to the front door of our healthcare system in this country. And that means affordable health coverage and high quality healthcare for everybody in this country. And we make progress, we make lots of steps forward, we take few steps backward, but at the end of the day, this is an arc that will always go in the right direction, irrespective of how many setbacks we have, until we get to a point where everybody has access to the front door of the healthcare system. We're always going to be trying to patch the system with a lot of Band-Aids. So I mean, that's really, it's the solution to this is more a policy solution where we guarantee access to more people to the front door of the health system, not try to figure out ways to cut people away from having health coverage and access to the front door of the healthcare system.
Two more questions, okay. The other piece, I teach medical students at UC Berkeley, and I often tell them that a healthy patient doesn't need a doctor very often, right? And part of the goal is to reduce the need for the sorts of MRIs and CT scans. And that, again, is a lot, in my mind, is a lot of what's happening here. Next question.
Dick Fleming from St. Louis, and extending on the last set of comments, looking at that $20-some trillion machine and looking at Washington, which has been giving democracy a bad name on this subject for the past year, how do you counsel and what do you suggest in terms of what we need to do at the national level? And do you see any hope that the Senator Alexanders and Murrays are going to come up with something that can work in the local setting that you have been articulating?
I mean, my initial thought is that this is something that was coming up while I was in medical school, back in the early 90s, was that our healthcare system was going to eventually be unsustainable. It was already clear where things were headed. I think that's happening right now. We're just bankrupt. The corporations can't afford it. The country can't afford it. And so I feel like strangely enough, despite the current political environment, there is a growing recognition that something has to change. And you see these weird things where some of the far right actually also are coming around to the idea that a single payer system or at least a universal coverage is going to be required. So unfortunately, I think part of this, the crisis that we're hitting, the unaffordability of the current system is making people recognize that the inefficiencies have to be addressed. And it really does come back to policy. But I think making the case for the costs of doing this badly is something we still need to make that case more strongly. Yeah. Do you have any thoughts?
I mean, to me, really, it boils down to three things. I mean, our healthcare system is not perfect. The ACA helped getting more and more people to get coverage, but it's not by any means that we have the perfect healthcare system. Any things that we need to do to improve on our healthcare systems today really need to have answers to three things. You need more people getting coverage. You need affordable coverage, like healthcare needs to be affordable, and you need to make sure that the quality is going up. So if we think about how do we get to making sure that more people getting coverage, more affordability is part of the equation, and quality is up, it requires a lot of work. It's not easy. If it was easy, it would have been done. And it truly requires bipartisan collaborative work that we're hoping will get back on track to think about all these things that needs to happen to improve the system that's on top of what it's today.
But I will add, though, and this is important, those are all absolutely true, but we also need far, far less chronic disease in this country. 80% of that $3.5 trillion is spent on chronic disease. Most chronic disease occurs among low-income people, and most low-income people live in low-income neighborhoods. So we have to reduce the number of people coming in needing the kind of care. They absolutely need insurance and coverage and good quality care when they need it, but we've got to reduce the amount of medical care need in the first place.
The concept of community, defining it a little bit more physically, co-locating mixed income housing in Stanford, where we see senior housing next to a community walk-in clinic. There are many threads going in the direction of putting healthcare into more place-based strategies, Main Streets, and how an anchor hospital can engender a whole a mix of development around it. And I'm curious, and I understand also the IRS allows and the community benefits that some of those fundings can go to physical infrastructure, bike paths, so forth. Mm-hmm. So I'm curious about the concept of a health improvement district. if 80 to 90% of health matters and behavioral of health outcomes relate to the built environment and behavioral, then you really are already in the health improvement district business. And I'm curious how you might take that next step where, in a smaller scale outpatient clinic, you encourage senior housing to be co-developed, where you start to play a role in some of the design of that place, or in the larger setting, how you go the next step and maybe encourage the kind of commercial that doesn't include alcohol in great abundance, or other things that build health, walkable, bikeable, access to healthcare, all in the mix, including for seniors. So health improvement district, do you think that would have traction also with other healthcare providers?
That's great. Do you want to add we'll see, so health
Yeah,
improvement,
we
I
actually
actually
are
don't know
very
much
much-
about those, so I'm going to rely on you.
Very much aligned.
Yeah.
We're very much aligned. I'm a pediatrician, but also have served as Director of Innovation in Public Health. I function at the intersect of health and education, and now spend most of my time in sort of community building sorts
where are
of
you based?
activities. I'm based here in Omaha, and I have a faculty appointment in prevention research at Penn State. And so, again, trying to bring it back to this audience and why I'm excited to be at Purpose Built. You, I think, stated, Dr. Jutte, you know, this problem of financial incentive alignment in the healthcare system. What if the money goes into one sector and the benefit is really felt in the healthcare system, for example? So you invest in housing and you get healthcare benefits. And then looking at where we're shifting from chronic disease to wellness and prevention, and our health system isn't set up that way. Bringing it back to this sort of thing, I think it is going to be the insurer side of the healthcare system whose incentive it is to keep people healthy. Do you see any progress towards dollars, again, being spent in these sorts of efforts, right? I mean, to me, why would the healthcare system not invest in a purpose-built community when we know full well that when we watch the video from like the graduating class from Drew, that those kids are not only going to be successful economically and in their work life and their, you know, graduate educations and things, but also in the healthcare system, right? Whether it's diabetes, heart disease, hypertension, obesity, all of these things that we know, the health system is going to reap those benefits. Do you see any mechanism coming for the money to cross over?
Okay, David's standing here, so I'm well aware of that. So very quickly, so health improvement districts and what's happening in terms of sort of changing the financing from the healthcare side.
Yeah, I mean, I can't agree with you more. The answer is yes, and we have to do that. And I think our experience at Kaiser Permanente and the work that we've done in Baldwin Hills Crenshaw Medical Office Building and a couple of the medical office buildings that we're working on right now is really the gist of what you described. And if folks are interested, we have like a 3.5 or so minute video about the exact same thing that you've described that I'm happy to send to the organizer of the conference so we can share with the group that answered that question.
Yeah, and similar on those points, there is movement in the Medicaid side, state Medicaid dollars being used this way. Insurers, United Healthcare has invested actually directly in affordable housing in places like Phoenix, which again, big private health insurer. And again, since we're right out of time, on our site, the Build Healthy Places Network.org, we have a series of case studies. And we have something called Crosswalk Magazine that writes, its journalists, colleagues of ours, have described some of exactly what you're talking about.
Thank you. Applause for the panel. Thank you so much. That was really great.